Everyone, and welcome to one more lecture of neurology, and this one is the part 4, and I hope so, like the last lecture, for what you can say, the examination. Okay, so our last video was finished on the topic of sensory examination. Now you can see they're showing two patients, and they're showing the pattern of their sensory impairment. In this one, the person have no sensations here, here, and here. It seems like the person is wearing gloves and stockings. So we in medicine call it as gloves and stocking fashion of impairment, which occurs in diabetic neuropathy. Now, see, for example, someone have a problem here in the brain. So of course, half of the body will be affected. Someone have a pathology in the spinal cord. All the area below this should be affected. So this pattern is doesn't going with any nervous system problem. Basically what is happening, the peripheral nerves which are supplying the distal parts of the body are affected. So this thing occurs in diabetes. In diabetes, we when you will study diabetes, you would know there is something called as diabetic neuropathy, in which what happens, the distal nerves of the body, they get affected. On the same hand, if you can see this one, see half the lower half of the body, this body have abnormal sensations. Now, when I will see that someone lower half of the body is gone, first of all I will think, okay, the problem is in the spinal cord. When I will examine him, I will found like there is absent pain and temperature sensation on this side, but preserved other sensations on this side. There is light touch and vibration are impaired, but pain and temperature are fine. So by my knowledge, I know that pain and temperature fibers, as soon as it enters the spinal cord, it cross over and then go up. Whereas this one, the light touch and all these things, they enter the spinal cord and goes up on the same side. So okay, now I know that someone have a transaction of the spinal cord on one side. So this syndrome is also called as the Brown Sequard syndrome. What happens in these patients is the half of the spinal cord have damage, and when half of the spinal cord is damaged, these fibers will be intact, but these fibers will be cut. And on the same side, the fibers which are going up from this side, the fast sensations will be affected, but pain and temperature will be intact. Okay, so let's continue and see what we will see in the video.
Sensation by applying a warmed or cooled tuning fork to the skin.
Is that cold?
Yes.
Is that cold?
Yes.
Assess pain sensation by applying a sharp object, such as a safety pin or broken tongue depressor, to the skin.
Can you close your eyes? Is this sharp or dull?
Sharp. Dull. Sharp.
Good.
Assess non-discriminative touch by applying a soft object, such as a cotton ball or tissue, to the skin.
Do you feel that? Do you
Yes.
feel that?
Yes.
Assess vibration sensation by placing a vibrating 128 Hz tuning fork to a bony prominence.
Close your eyes. Do you feel the buzzing?
Yes.
Okay, can you tell me when that goes away?
Okay.
Good.
Assess proprioception by stabilizing the joint and moving the distal end up and down. Ask the patient to report what they feel.
I'm going to move your hand up or down. Tell me which direction it's moving.
This is what they are checking is proprioception. Now see, when they check the sensory system, like what they do is like they check the pain and temperature sensation. So which pathway they're checking? They are checking the spinothalamic pathway, the blue line. Okay. And on the same side, like the use, we can use a pen, and which should be sharp. So we can just apply that lightly, okay, not so hardly. And we ask the patient to close the eyes and see, like ask them like either they feel it sharp or dull. So when we examine the patient in this one, basically what the knowledge we must be having is what is the knowledge of the dermatomes. Okay, the knowledge of dermatomes is very important in this one, because what we check in this, we check it in dermatomal fashion, and we always keep on comparing the left side and the right side. And same thing with the temperature sensation. Of course, don't apply too much hot. Of course, the patient will get hurt from that. But like you can say, like the hot things which you apply should be around 40 degrees centigrade, and the cold things should not be lower than 5 degrees centigrade. 5 to 10 degrees centigrades are normal. The tuning fork is metal, and that's the best way. When we apply, so they can feel the temperature distance. And see, when he checked the proprioception or vibration sensations, basically what he's checking is the posterior columns. Okay, so uh, the fibers of posterior column, they ascend ipsilaterally. You can see ipsilaterally they ascend. Okay, and then in the medulla, what happens, like they cross over to the other side. Crossover is also called as decussation or decussate. 128 hertz megahertz tuning fork should be used. Ask the patient to close the eyes and then place the vibrating tuning fork on a bony prominence. That's a very important thing. Okay, so now basically, what this proprioception have an interesting uh, thing as well. There was a there was a guy named as Sir Charles Bell in 1826. Basically what he said, like he recognized like people have a sixth sense, which he named as proprioception. So like the vibration sensation was recognized in 16th century, but this guy, what he's checking right now is proprioception. It was discovered in 19th century. So he's the one who found, like not he, like he described, and then later on there is someone who found like the vibration sense and the proprioception, they were carried in the posterior columns. So this thing. So when we check the proprioception, we basically use the distal interphalangeal joint of the patient, and when their eyes are open, we just tell them this is up and this is down, and then we ask the patient again to with the eyes closed. And so normally, a movement of few degrees is detectable by normal people. So light touch can be checked by touching the cotton wool. So this is how we do. So you can Google, or you can open your books and see the dermatomal chart and see like how the different dermatomes of the body, they are supplied by which nerve roots. For example, the middle finger, it's very easy to remember. It is supplied by C7, and if the middle finger is supplied by the C7, the thumb is supplied by C6, and the little finger is supplied by C8. So easy way to remember, not so hard. And then you must know, which peripheral nerves are supplying which muscle groups. Of course, that's important, because sometimes it is not the spinal cord which is affected, rather it's the peripheral nerve which is affected. So that's a very important part to understand here. Okay, so let's continue with this lecture.
Can you close your eyes?
Down, down, up, up.
Excellent.
Sensory information travels to the brain along one of two main pathways in the spinal cord, the spinothalamic tract and the posterior column medial lemniscus tract. Test for one modality from each spinal tract to assess both pathways in your exam. Due to the large number of areas and modalities that can be assessed during the sensory exam, this part of the exam must be tailored depending upon the clinical context. Focus your efforts on the affected area in order to determine the pattern of sensory abnormality. Depending on the site of the lesion, sensory deficits can present in a variety of patterns. For example, a lesion at the spinal nerve level will present in a dermatomal pattern. In contrast, a lesion at the peripheral nerve level will present in a peripheral nerve pattern, either as a mononeuropathy, where one nerve is affected, or a polyneuropathy, where multiple nerves are affected. If you detect an abnormal sensation on the middle finger, it may be due to a median nerve problem, or it may be due to a C7 spinal nerve problem. These two lesions can be differentiated by carefully mapping out sensation on the rest of the hand. It's important to note that other patterns of abnormal sensation exist, but carefully mapping out any abnormalities and comparing this pattern to a dermatomal and peripheral nerve distribution is a great place to start.
So that's the completion of the neurological exam, the motor and sensory components. Thank you for your time.
Okay. Okay, so you can see in this one, this video, like what he said in the last was like how to do the things, okay, and what are the information which must be known and to reach the correct diagnosis or reach the correct area which is affected, okay. So that's what I was telling you. So now what is left, like how I started my discussion was basically from this thing, like instead of teaching you like first motor and then sensory, I am taking you in other way, like how we do in reality, okay. And that is like this thing, ITP or CS, right? So inspection, tone, power, reflexes, coordination, and sensations, right? So you have seen how to do reflexes, you have seen how to do the sensation, you have seen how to check the power and the tone. So what is left is this coordination. So coordination is basically the function of cerebellum, okay. So when we check the upper limb, by the way, we check the coordination in the upper limb, and we examine the lower limb, we examine the coordination in the lower limb, and then we check the sensations, okay. So of course in this one I'm taking you in a different way. So the video which I will be running now is about checking the coordination in the gait, like how they check in the real life, and what are the abnormality which I've seen. Again, I'm mentioning you guys, you can watch this video, it will help you a lot, called as UBC medicine cranial nerve examination, okay. A very helpful video, like it will give you maybe, and when you will study it from the book, the things will appear easy for you. So now we are going to see the other video. So this one is about gait and coordination examination.
We will start with an assessment of upper and lower limb coordination, then proceed to assessing balance with the Romberg test, and finish our exam by examining gait.
Hi, Pauline. I'd like to conclude the neurological examination with an examination of your coordination, balance, and gait. Is that okay if we proceed? Great. I'll just be asking you to do various movements with your limbs and walk for me in certain ways, okay? Okay, great. We're going to start with an examination of the coordination in your upper extremities. We're going to look at fine finger movements first. So what I'm going to ask you to do one hand at a time is you're going to take your index finger and tap it into the crease of your thumb like this, trying to make quick, regular movements like that, okay? Could you try that with your right hand, please?
There are many ways to test for fine finger movements, but one common exam is this finger-thumb test. Look for rate, rhythm, amplitude, and accuracy. Abnormalities in these parameters can indicate different pathologies, and this will be addressed in a separate video.
Great. That's good. So I was looking for the rate, rhythm, amplitude, and precision of your movements, and they were brisk. They had a good regular rhythm. Amplitude was full and nice and precise and equal on both sides, so that's completely normal. So we're going to move on to testing rapid alternating movements. There's many ways to do that, but the way I'd like you to do it for me today, please, is you're going to put your right hand over top of your left hand, and you're going to go back and forth like this, again trying to do it quickly but making a full movement and aiming for the same spot every time. Okay? So could you start with your right hand on top of your left hand and try that for me?
Look for rate, rhythm, amplitude, and accuracy of the movements.
Try that with your left hand now. That's great. Okay. We'll move on to doing the finger to nose test. So as you can imagine, this requires you to take your finger and you're going to touch your nose, and then I'm going to hold my finger out in front of you, and you're going to go and touch my finger and go back to your nose, back and forth like this, okay? So could you take your right index finger and touch your nose, and then come and touch my finger here, and go back and forth, back to your nose, back to my finger.
Look closely for accuracy of the patient's finger and for presence of intention tremor.
Great. Let's try that with the left arm now. So take the index finger, touch my finger, go back and forth. That's great. Okay.
Okay, guys, first of all, remember this thing that see, whatever he's checking on both sides, because if you have seen a patient of, for example, I'm again and again giving you the example of stroke. If you have seen a patient of stroke, stroke affect one side of the body. So that's very important to check. And again, the rule of the medicine, whenever there is a pair, always compare, right? So see, even he's comparing. So see, he did the rapid alternating movement test, and he asked like the finger thumb test. These are basically cerebellar functions. Now, uh, again, I expect from you more, like you must study yourself the neuroanatomy, but of course, to take you with this thing is cerebellum have multiple connections, both the afferent and efferent, to sensory pathways. Okay, it have connections with the brainstem nuclei. Cerebellum have connections with thalamus, and cerebellum have connections with the cerebral cortex. So due to these connections, cerebellum is coordinating all the voluntary movements which you are doing. Like if your movements are smooth, so it means your cerebellum is functioning fine. Okay. So whenever we check the cerebellum function, okay, this is not the only function to check for the cerebellum. There are many other things like cerebellar problems give nystagmus. Okay. Cerebellar conditions can give tremors. Cerebellar conditions or diseases, the patients have abnormal speech. They have past pointing. They have dysdiadochokinesia. They have hypotonia. Okay. They have a lot of things. A lot of conditions are there. The finger nose test, which you can see over here, like he asked the patient to touch his, or like in this case her nose with the index finger, and then touch the examiner finger, okay? And he places his finger almost at her arm length, like, which is basically when you will in full extension of the elbow as well as with the shoulder. And the touch should be done first in slowly and then quickly, quick fashion or brisk fashion. So, and can be repeated number of times, So this thing is important. So what we look is, see, he said rate, accuracy, and all this stuff. Basically, what you must look is number one for intention tremor. For example, in cerebellar conditions, there is no tremor at rest. Rather, when the patient is approaching his target, okay, like as she will touch her nose and take her finger to the examiner's finger, as she will be close to approaching the target, she will be having a tremor. Okay, this is called as intention tremor. Okay, this is called as intention tremor. So one of the things which we are checking in these patients when we are doing this is basically intention tremors. So there is no tremors at rest. The other thing which we have to notice is pass pointing, where the patient finger basically don't hit the target, rather overshoots. She will not touch the examiner finger, but her finger will go further towards the examiner. Overshooting is there. That shows cerebellar abnormalities, okay? This shows cerebellar abnormalities. And if you can see over here,
Different
this is the
pathologies.
fast
And
movement.
this
Completely normal. So we're going to move on to testing
See,
rapid
what
alternating
he's doing
movements.
here.
There's many ways to do that, but the way I'd like you to do it for me today, please, is you're going to put your right hand over top of your left hand, and you're going to go back and forth like this. Again, trying to do it quickly, but making a full movement and aiming for the same spot every time. Okay? So could you start with your right hand on top of your left hand and try that for me?
Look for rate, rhythm, amplitude, and accuracy of the movements.
Try that with your left hand now. That's great. Okay.
Okay, see, what he's doing is he's checking rapidly alternating movements. If anyone cannot perform this rapid alternating movements or inability to perform rapid alternative movements, it is called as dysdiadochokinesia. This is called as what? Dysdiadochokinesia. So we ask the patient to pronate and supinate his or her, in her case, her hand on the dorsum of the other hand as quickly as possible. Okay. When the patients who have cerebellar condition, so this movement is very slow and clumsy, which shows that the patient have some cerebellar condition, or you can say that the patient have dysdiadochokinesis or dysdiadochokinesia. Okay, so this thing is very, very, very important thing to check. So this is not only get affected in cerebellar conditions, but rather in Parkinson's disease as well. Like the patients, they cannot perform rapid alternating movements. Okay.
Move on to doing the finger to nose test. So as you can imagine, this requires you to take your finger and you're going to touch your nose, and then I'm going to hold my finger out in front of you and you're going to go and touch my finger and go back to your nose, back and forth like this, okay? So could you take your right index finger and touch your nose, and then come and touch my finger here and go back and forth, back to your nose, back to my finger.
So you can check
Look
intention
closely
tremors
for accuracy
and
of the
pass pointing.
patient's finger and for presence of intention tremor.
Great. Let's try that with the left arm now. So take the index finger, touch my finger, go back and forth. That's great. Okay, that was normal on both sides. So next we're going to move on to tests of the lower extremities, and for the first couple of tests I'm going to want your feet against the floor, so I'm just going to reach and get a stool for you to sit on, okay? So would you mind coming sitting on the stool? Great. Sit nice and square with your feet on the floor, and we're going to look at some toe tapping. So 1 foot at a time, I'd like you to tap your toes like this, as if you're tapping along to music. Make the movements as large and quick as you can. Okay?
Look for rate, rhythm, amplitude, and accuracy of the toe tap.
Great, and try that with the left foot. Normal and symmetric on both sides. That's great. We're going to move on to heel tap.
Okay, now what this is foot tapping test. This foot tapping test is he's checking rapid alternating movements in the lower limb. Okay, so if, for example, if you are examining someone's lower limb, so you will go in the same fashion: inspection, tone, power, reflexes, coordination, and sensation. So you can ask the patient to do this rapidly alternating movements in the lower limb by tapping the sole of the foot quickly, sometimes on the hand, or tap the heel on the opposite shin. Okay, so and we check for these things, either the patient can perform this thing or not.
Now, so this time I'm going to ask you to lift your whole leg off the floor and tap your heel on the same spot.
See,
Again,
he's using
try to
now
make the
heel now.
movements nice and quick, and try to lift your heel about 10 centimeters off the floor. So what I mean is something like this. Just tap like that. Try that with your right leg.
Again, look for rate, rhythm, amplitude, and accuracy of the heel tap.
And try it with the left leg. Great. Again, that's normal on both sides. So the next test we're going to do is the heel to shin test. For this one, I'm going to ask you if you can just lift your gown up so we can see your shins. And what I'm going to ask you to do is to take your heel and put it onto the bottom of the opposite shin and slide it up along your shin up to the knee and back down again over and over again in a smooth, rapid movement. Okay? I'll show you what I mean. So you put your heel on your shin and up and down like this. Try that with the right leg on top of the left leg first. That's great. Could you try that with the left heel on top of the right leg?
This test can be done either with the patient sitting or supine. Look for smooth, coordinated movements of the heel.
Perfect. That's normal on both sides.
So you can see over here, he asked the patient to run the heel of 1 foot up and down the opposite shin. Don't ask them to do it at very increased pace. Rather, a moderate pace is fine. And ask the patient to do it as accurately as possible. So when there is cerebellar conditions, okay, what happens, like when the patients they do this thing, their heel basically wobbles all over the place, and sometimes there could be overshooting. So this is like what happens in the patients who have uh, cerebellar conditions, right? This is how they present with. So now let's move forward to what you can say the next part, that is the gait. And I told you the gait examination is done in the patients who have like lower limb problems, stroke. There are different type of cerebellar conditions. They give a different gait. Anyone who have foot drop, they have a different gait. Anyone who have you can say some pain in the joints, they have a different gait. So make sure when you are examining the gait of the patient, the legs are clearly visible, and ask the patient to walk normally for a few meters and then turn quickly and walk back to you, and also ask them to walk on the heel and then walk onto the toes, or heel to toe walk should already also be asked. So when we ask the patient to walk on the toes, by the way, we are checking the S1 nerve root, because S1 is the one uh, which causes plantar flexion. And when we ask the patient to walk on the heels, basically we are checking L4 and L5, which are there, which produce dorsiflexion. So we also do one test called as Romberg test. Okay, so I will explain you once we'll do that.
Okay, Paulina, we're going to look at your balance and gait now. Would you mind coming off of the bed and standing up? We're going to do the Romberg test now. I'm going to ask you to stand with your feet close together like a soldier at attention, your arms down the side, close your eyes and hold your balance like that. I'm going to watch you to make sure you don't fall, okay?
The human body maintains balance through three systems: proprioception, the vestibular system, and vision. Two of these three body systems must be functional to maintain balance. When a patient closes their eyes during a Romberg test, vision is eliminated, so proprioception and vestibular function must both remain intact to maintain balance. If the patient cannot balance after closing their eyes, this, in conjunction with other consistent findings from a neurological exam, may signify that their proprioceptive or vestibular function has been compromised. Have the patient hold this position for at least 15 seconds. Patients with a positive Romberg sign will sway noticeably and may fall, so make sure to stand behind the patient to catch them in case this happens. While this is not necessary, you can test for pronator drift at the same time.
Okay, very important thing, guys. If you have noticed, I don't know how many of you have noticed this thing. See, we must be careful with the patient. Of course, like the subject which they took in this exam is a normal patient, but the patients who have stroke or who have some problem with the gait, when you're performing gait examination or Romberg test, for example, you must be very careful, because if your patient will fall, of course, like he can get injured, especially old people. When they get their head hit somewhere, they may have hemorrhage. Okay, so be very careful. Don't let your patient fall. And when you're performing these tests, you must be at the side of the patient, so that the patient should not get injured or should not fall. So if you can see the Romberg test and they try to explain you what is Romberg test is used for, first of all, we ask the patient to stand up and with the eyes open, and then we ask the patient to close the eyes, because to maintain our balance, we need visual input. There is a vestibular system inside the ears which help in maintaining the balance. And the third thing which plays role is the proprioception, the information which is coming from your nerves, from your joints. Okay, so when someone eyes are open, of course he is looking everything from the eyes, and if his balance is going out and he is falling on one side, of course, like the input from the eyes basically helps you to maintain the balance. So then we ask the patient to close the eyes, because we are stopping one kind of input, which is the visual input, so that we want to check like either the vestibular system as well as the information which is coming from the joints position or the proprioception information are working or not. So we compare the steadiness of their gait with eyes open and then closed for around 1 minute. So by the way, like sometimes in absence of neurological condition, maybe the patient become a little unsteady. Okay, like a little unsteadiness is there, in not in all but like in many. So normal people basically they can maintain the position usually for 60 seconds. You can check yourself. So we say that the Romberg test is positive when there is unsteadiness with the eyes closed. Okay, so this is usually seen with the loss of proprioceptive sensations, which are coming from the joint position sense. Okay, which is coming from the joints. Okay, so this is the basics of the test. So we we take away one kind of input, which is the visual input. When that input is gone, so if the patient have unsteadiness, so it means like there is some problem with the joint sensation. Okay, so if the patient have unsteadiness with the eyes open, Like the eyes are open and still the patient is unsteady, it means like the condition can be due to cerebellar problem or vestibular problem. Okay, so this is the basics of this Romberg test. I hope you understand. By the way, not a big thing if you have good concepts, right? So now we will go on to the gait, and the gaits are many. There is hemiplegic gait, in which the foot is plantar flex and the leg is swinging on one side, taking a big arcs type of movement. There is spastic gait, there is Parkinson's gait, there is cerebellar gait, there is foot drop gait, there is proximal myopathy gait, and all these things. So you can see over here.
Before the patient begins to walk, observe to see if the patient is using any gait aids, such as canes, poles, a walker, orthotic shoes, or knee braces. Watch as the patient stands up. Can they stand up smoothly without extra help or effort? As the patient begins to walk, inspect the patient's movements as he or she walks normally. Pay close attention to stance, stride width, stride length, step height, gait speed, arm swing, and 180-degree turns. It's good practice to pay attention to these clues when the patient first enters the room while the patient is not feeling self-conscious about their gait.
That's great, thanks, Paulina. Now I'd like you to walk a tandem walk, heel to toe, as if you're walking on a tightrope.
Having your patient demonstrate a tandem gait will exaggerate strain on the postural reflexes, bringing out any truncal ataxia. Note that abnormalities in tandem gait may also be due to poor proprioception, vestibular function, and leg tremors, in addition to a cerebellar lesion.
That's great, you could do that normally. I'd like to watch you walk on your tiptoes now, up on your toes, please.
Having your patient walk on their toes will test their plantar flexion from the gastrocnemius and soleus muscles, supplied by the S1 nerve root.
Great, okay, now could you walk back to me on your heels?
Having your patient walk on their heels will test their dorsiflexion from the tibialis anterior muscle, supplied by the L4 nerve root.
Thank you, Paulina. That concludes the gait exam. Everything looked really normal.
Okay, so you can see like these videos are so helpful, and you can see like how he asked them to walk on the heel and on the toes, right? And what they're checking is like L4, L5, and S1. Once you will do that, though there are many other things, which we do in the neurological examination, beyond the scope of this lecture and beyond your scope as well, because these are the basics which every medical student should know, and you must know as well. So I hope you understand how the neurological examination it works, and what are the parts. Again, starting from our first lecture, starting from the general appearance, taking vitals, doing heart examination. Why we do heart examination in neurology? Because one condition is called as atrial fibrillation, like in which the atria they are beating so fast, like the speed of the atria beating is basically more than 350 beats per minute. So practically speaking, the atria, there is just electric impulses which are passing through the atria, but the muscles are not contracting, like there is no efficient pumping is going on. So there can be a clot formation in the atria which can lead to stroke. So we always check the heart sounds, we always check the pulse, because in atrial fibrillation the pulse is irregularly irregular. So anyhow, then we go for GPE. We do a um, mental state examination. We can do a mini mental state examination. We do a cranial nerve examination. we do a upper limb examination as well as lower limb examination. And if you want to divide it another way, then you can go like this way, that we go for a motor examination, we go for a sensory examination, we go for reflexes examination, we go for coordination examination, right? If you want to go in this way. So, but usually, like, it is the upper limb and the lower limb we test rather than going in other way. So, um, one lecture I think, like, which I should add on in this one is like about the cerebellar conditions, right? So that like this neurological examination will be completely finished, right? And then when you will study neurology, you will be having a lot of information beforehand, which will help you a lot. Okay, so see you guys for the last lecture for neurology, which will be about cerebellar conditions, okay, in the next video. Thank you so much.